The topic for today is Renal, and we are going to have a CCS session. The speaker that we have here is Dr. Nikhilesh Jain. He's a director and operational head depth of critical care services care at CHL Hospital Indore. So you may take over. Thank you.
Okay. So you've got a 34-year-old male who presents to the emergency department with severe muscle pain, dark colored urine, and generalized weakness for the past 24 hours. Feel free to interrupt if you think that you have not got the question. Now, he reports completing an intense CrossFit workout 2 days ago, which included multiple sets of weighted squats and deadlifts. He denies any prior history of similar symptoms. So I'm going to add some more details in this. So vital signs are BP is 125 by 80 mm of mercury. Heart rate is 98 beats per minute. Temperature is 37.3 degrees centigrade and respiratory rate of 16 breaths per minute. He is alert and oriented, appears uncomfortable due to muscle pain. He's got a bilateral thigh and calf tenderness with mild swelling. No focal deficits, normal deep tendon reflexes. Elevated serum myoglobin levels and serum creatinine levels are seen with low urine output. And this is the color of the urine that's been put on the side. So what do you think is this?
Rhabdomyolysis.
Yeah. This looks fairly clear and easy. This is rhabdomyolysis. The type of questions that can come out of this is, and the type of offshoots that can go out of this is, so what is the diagnosis has been well answered. Basically, there is a list of electrolyte abnormalities which are seen commonly in rhabdomyolysis. One, so you need to know all about them, especially with reference to your calcium disorders, phosphate disorders, everything. And at what stage of rhabdomyolysis are they seen? That is one. What is the diagnostic test? That is something you need to know. You need to know whether there is any role of urinary alkalinization. You need to know drug-induced causes of rhabdomyolysis and list the complications of rhabdomyolysis. In addition to that, you can have an offshoot wherein they may ask you about the timing of renal replacement therapy. It can go on to that tangential. It can go on to a tangential of definitions or various criterion for defining acute kidney injury. Am I clear? So we go on to the next CCS. You've got a 72-year-old male with a history of hypertension, type 2 diabetes mellitus, chronic kidney disease stage 3, presents to the emergency department with chest pain radiating to his left arm. An urgent coronary angiography with contrast was performed and it revealed a significant coronary artery disease. When we look at his past medical history, he had hypertension, he had type 2 diabetes with a HbA1c level of 7.8%, CKD stage 3 with a baseline serum creatinine of 1.6 milligram per deciliter, and the medications he was on was metformin, lisinopril, aspirin, as well as atorvastatin. He did not have any allergies, and in the recent procedures, he has undergone a contrast-enhanced CT angiography about 2 weeks ago. So these are his vital signs: BP of 138 by 84 mm of mercury, heart rate of 76 beats per minute, respiratory rate of 18, and temperature of 36.9 degrees centigrade. On general examination, there was no distress. Patient is alert and oriented. Cardiovascular point of view, there are no murmurs or no signs of heart failure. Renal point of view, there is no costovertebral angle tenderness. There's a mild bilateral lower extremity edema. 48 hours after the coronary angiography, the patient reports decreased urine output and generalized weakness. The baseline creatinine, which we went through the earlier slide, which was 1.6 milligram per deciliter, has climbed up to 2.3 milligrams per deciliter. That is a 48-hour increase by about zero point 0.7 milligram per deciliter. You've got a blood urea nitrogen of 38 milligram per deciliter, which is elevated. There is mild hyperkalemia, 5.2 milliequivalent per liters, and urine analysis shows muddy brown casts with no proteinuria. So can anybody tell me what is happening here? You can put it in the chat
Contrast,
box.
contrast-induced nephropathy, perhaps leading to rhabdomyolysis and generalized muscle weakness.
Why you are thinking in terms of rhabdomyolysis here?
This generalized weakness is also there,
So
and
can it
there's
not be a
muddy
part
brown
of
casts.
worsening of renal dysfunction? There's nothing to indicate in the history here that that this patient has rhabdomyolysis. I would definitely grant you contrast-induced nephropathy. So what are the type of questions that again you are going to look at? So what is the diagnosis? Told very clearly. So can you establish a causality for the same and what are the risk factors? So you need to know the risk factors for developing contrast-induced nephropathy. One, can you establish a causality? Causality meaning, can you establish the fact clearly that this is happening because of the coronary angiography and the contrast exposure? You need to know certain risk prediction models, especially the Roxanne-Mehran risk scores. You need to know the preventive measures, including hydration, role of N-acetylcysteine, certain other measures, how they do it, and any correlation with other contrast agents in the sense, what would be something that you would like to use? You would like to use isoosmolar, would you like to use hyperosmolar, hypoosmolar? And how are the type of contrast agents going to fare in terms of being a causative etiology for acute kidney injury for this particular subgroup of patients? And what would be the sort of evasive measure that you would like to use, especially in a patient who has undergone coronary angiography with a background of CKD, right? Next case vignette, just put your answer in the chat box. A 28-year-old woman, gravida 2, para 1, presents to the emergency department 1 week postpartum with complaints of severe headache, confusion, bruising, and dark colored urine with a history of normal vaginal delivery at 39 weeks without any complications. Now, vital signs include a BP of 148 by 92 mm of mercury, heart rate of 110 beats per minute, temperature of 37.2 degrees centigrade, and respiratory rate of 18%. On general examination, the patient is pale, mildly jaundiced, alert but confused. Neurologically, this patient is disoriented to time and place, no focal deficits. Skin is suggestive of multiple petechiae and ecchymosis on the upper limbs. And abdominal examination tells you about soft, non-tender uterus, which is well involuted. So what do you think you are looking at here? Any guesses?
Postpartum eclampsia or pre-eclampsia.
Okay, everybody seems to get towards help. Okay, so let's see what happens here. We go on to the next slide. So you get a platelet count, which is 18,000 per microliter, severe thrombocytopenia, with hemoglobin of 8.2 grams per deciliter. Schistocytes on blood smear. You've got an LDH value of 950 units per liter, which is elevated. Haptoglobin is undetectable. Creatinine of 2.1. Acute kidney injury. Indirect bilirubin is elevated. Coagulation studies are normal. And you've got an ADAM TS13 activity, which is less than 10%. So do the answers change now? They do. Answers now have changed. Correct. So the moment I put ADAM TS13 activity, suddenly it becomes very clear what we are talking about, right? So in this patient, you need to know about the diagnosis. You need to know about the pentads, tetrads, and all those things. You need to know about the confirmatory test and how well to define it. Where all can you get a false positive and a false negative? You need to know the algorithm, specifically the pregnancy specific algorithm for validating that this patient is indeed having a TTP related to pregnancy. You need to know the treatment for the same, how long you want to do the treatment, how many sessions you want to do. Are there any special precautions that you would like to use? And of course, the differential diagnosis which can come out of this, right? This can
Sir,
also
if
be
we
in
are not, sir, if
yeah.
we are not given the ADAM-TS levels and just the clinical vignette, then should we be able to, I mean, then
Still, TTP would be one of the differentials here. Did you look at the overall symptomatology? I'll go back to the slide. Just look at this. This patient had neurological problems, right? This patient had skin issues. This patient had thrombocytopenia. This patient had a MAHA, schistocytes and blood smear. So she had a microangiopathic hemolytic anemia. She had evidence of hemolysis in the form of LDH. She had acute kidney injury in the form of elevated creatinine of 2.1 and indirect bilirubin elevation. Coagulation studies were normal. Even if I do not mention the ADAM TS13 activity, it is very clear that we are looking at one of the differentials of TTP very likely. Right?
because MAHA is there and AKI is also present with neurological features, so we should think of TTP. That's
Yeah, you have evidence of hemolysis as well, no? LDH 950. Do you think that with a normal fibrinogen D-dimers, you would have thought of it as DIC? It is not, right? So there are pregnancy-related specific scores. You should know them. You should know the treatment. You should know the finer points of plasmapheresis of legs. You should know about how well you want to use them. In the sense that if there's any differential or specific modality of flex that you would like to look at, and of course differentials. If I wouldn't have put Adam TS13, what should have been your differentials? That comes into picture. So that is something else that you should discuss. This is the fourth case vignette. Now these case vignettes are ideally supposed to give you a very broad idea of the type of questions that you're going to face in your EDIC. And you should have your preparation revolving around tangential questions which can come out of these. So it's basically a 54-year-old male, recently diagnosed acute myeloid leukemia, and it presents to the emergency department with complaints of nausea, vomiting, muscle cramps, and decreased urine output 2 days after starting induction chemotherapy with cytarabine and daunorubicin. Now, this guy has got a past medical history of hypertension as well as hyperlipidemia. The medications he is currently on are amlodipine and atorvastatin. His recent symptoms include fatigue, weakness, nausea, and dark colored urine. Vital signs are 130 by 85 mm of mercury, heart rate of 102 beats per minute, temperature of 37.1 degrees centigrade, respiratory rate of 18 per minute. Patient appears to be fatigued, mildly dehydrated with oliguria, and muscle weakness with cramps. Okay. So this time everybody has jumped the train. This looks very obvious. Some more details, ECG findings wise, peak T waves and widened QRS. Creatinine levels of 2.4 milligram per deciliter in form of acute kidney injury and BUN of 34 milligram per deciliter, right? So the questions that would come out of this is what is the diagnosis? Well, most of you have given that. Now do remember that when we talk about electrolyte abnormalities, there are two disorders. One is rhabdomyolysis and another one is tumor lysis. So you should be familiar with the set of electrolyte abnormalities that are there for rhabdomyolysis and the set of abnormalities which are there for uh, tumor lysis syndrome. When it comes to treating this patient, you would go on to all your routine stuff plus rasburicase, and there is a way to grade tumor lysis syndrome. You should be knowing that. Another thing, what is the point in time when you think that renal replacement therapy would be indicated for the same? And if so, which modality would be preferable? All these questions you should be able to answer, one. And secondly, again, in all of these questions, the offshoot of one, whether what is the classification of AKI and what levels you would call it can come into play. Then you need to know your trials of initiation of renal replacement therapy and when to replace it. What are the evidence-based benefits or what are the evidence-based results in terms of when you would like to initiate your RRT? Uh, they would also like you to know when if there was any superiority of CRRT for any particular indication. So all these things would come into picture. So there's a last case, You've got a 32-year-old male farmer who is brought to the emergency department 4 hours after ingesting poison in an apparent suicide attempt. Now, this guy complains of a burning mouth pain, nausea, vomiting, and difficulty in breathing. His family reports finding an empty pesticide bottle near him. Vital signs include BP of 110 by 70 mm of mercury, tachycardia, heart rate of 115 beats per minute, respiratory rate of 24 per minute, temperature of 37.2 degrees centigrade, SpO2 of 91% on room air. On general examination, this patient is conscious but distressed. There is moderate dehydration. Oropharyngeal wise, there are oral ulcers and mucosal burns. Our respiratory examination shows mild tachypnea with bilateral lung signs in the form of crackles. Cardiovascular wise, he has tachycardia, no murmurs. GI wise, he's got mild epigastric tenderness, no cardio. So, can I get any guesses here? This is fairly common. I mean, why is everybody so sorry. Alkali poison? No, 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 John. Absolutely not. This is a very characteristic poison, John. Any other answers? OPP. How can OPP be here? See, all of you have got insider information. I call it as an insider information because you know that I'm going to do the renal domain. So you cannot put an option of organophosphorus poisoning here. Please understand. Correct. Jagan, you got it correct. Jagan gets it correct. It is indeed paraquat poison. So arterial blood gas shows you metabolic acidosis. Hypoxia in the form of, I won't say called hypoxia, but low PaO2s in the form of PaO2 of 78 mm mercury. Renal function wise, creatinine of 2.3, acute kidney injury, and BUN of 38 milligram per deciliter. Liver enzymes are mildly elevated. There's mild hypokalemia. And when you do a chest X-ray, there are diffuse bilateral infiltrates, early lung injury. Right? I could have, sort of spiced it up by putting it up as a pneumomediastinum or something of that sort, because these type of findings are also reported in paraquat poisoning. So what is the diagnosis? We've gone through that. How do I confirm the same? This is something you should know. And there's a pictorial quiz also regarding the same. Again, I'm leaking that out. You need to know about the dithionite test. How do you need to treat the same? What is the role of, hemoperfusion, or what is the type of modality of RRT that you should use? That becomes important. Correlation with serum creatinine levels, especially with reference to defining the prognosis. You need to know the predictive nomograms that are available for paraquat poisoning. And of course, the role of cystatin C levels in terms of monitoring the same. Right? So, doubts. I've done my 5 questions. And in all of them, I told you that there will be tangentials of trying to lay down the criterion of acute kidney injury, trying to define the correct time of doing your RRT, trying to see if which modality of RRT goes through. And of course, like when you're doing which modality of RRT goes through, you also need to have a fair bit of idea on how you are going to, take these questions. Certain extensions of these questions would be, say, questions going on to CRRT, coagulation related questions, coagulation monitoring related questions on CRRT, types of CRRT, which is not the scope of questions today. And of course, troubleshooting on CRRT, which can be asked as further extensions of all of these. Any other doubts? I'll be closing off, and I apologize that because of Zoom link acting up, all sorts of mess happened in the initial 10 minutes. Everybody has become silent. You can put your things in the chat box. Even in these 5 CCS, there is a lot of data that has been covered. So your homework would be to go through all of these things. This is a lot of stuff. And do remember, electrolyte abnormalities, rhabdomyolysis, as well as tumor lysis syndrome. They're slightly different and they tend to cause confusion. My best thing would be that you should, sort of go through it or probably mark it up, which you need to read with extra care, because that is somewhere where people can get confused, right? Thank you, everyone, and have a very good evening, all of you. Thank you so much.
Thank you, sir.